Okay, now we'll talk about systemic sclerosis. Whenever you find a question about systemic sclerosis, remember it is about the complication the examiner is asking because everyone knows about systemic sclerosis. Whenever you are going for USMLE Step 2, you'll have to prepare for complications of systemic sclerosis. Whenever they talk about the complication of systemic sclerosis, the most important complication is involvement of the lung. What does it involve? Interstitial lung disease and pulmonary arterial hypertension. We discussed in pulmonology that whenever there is pulmonary arterial hypertension, the examiner will mention that this is a 35-year-old female patient who develops a gradual onset of shortness of breath, which is really worsening. And now on examination, this patient has got loud P2, that is loud second pulmonary component. What is your diagnosis? Simply pulmonary arterial hypertension. This is a normal question. But if the patient has got a systemic sclerosis, the examiner will mention that this patient has got telangiectasia, patient has got digital ulcers, patient has got difficulty swallowing, patient has got joint pains, is currently and constantly wearing gloves, not exposed to the cold. This is what you'll have to identify pulmonary hypertension as a complication of systemic sclerosis. Whenever we talk about the pathogenesis of systemic sclerosis, it is a progressive tissue fibrosis and it also involves vascular components. Whenever it involves vascular components, it causes Raynaud's phenomenon and digital ulcers. We talk about systemic sclerosis. So the systems are sclerosed. Whenever systemic word happens to be occurring in medicine, it is the constitutional symptoms that the patient present. Say, for example, the patient presents with fatigue, weight loss, patient presents with tiredness, weakness. This is how the patient describes. When we talk about the differential components or differential systems of what the systemic sclerosis involves, it involves the skin, which causes telangiectasia, it causes the digital ulcers, it causes calcinosis cutis. Whenever there is gastrointestinal involvement, it is basically because of the esophageal dysmotility or esophageal dysphagia, or the patient can present with postprandial abdominal pain, that is dyspepsia. Remember, Raynaud's phenomenon is completely vascular. What did we learn? It is the anti-nuclear antibody and anti-centromere antibody that we need to test. When we talk about the other complications, the examiner can also mention that there is a middle-aged patient who is basically got a background history of systemic sclerosis that is diagnosed, and this patient presents with gradually worsening shortness of breath. What do you think of this? Is interstitial lung disease. Whenever there is interstitial lung disease, the patient symptoms tend to be gradual and progressive. Very important. So, in interstitial lung disease, this is a restrictive disorder. So, the examiner will tell you that the ratio of FEV1 by FVC will be normal. I understand that most of the books and the question banks mention that the restrictive lung disorder FEV1 by FVC is increased. But remember, for systemic sclerosis question, whenever the examiner wants you to test for interstitial lung disease, you will see FEV1 by FVC as normal or increased. Remember that this patient, the systemic sclerosis patient, whenever the patient has got renal involvement, it is mostly the microangiopathic hemolytic anemia that the examiner will test you. Examiner is not worried about hypertension or anything. He's worried about microangiopathic hemolytic anemia because as a resident doctor, you must diagnose microangiopathic hemolytic anemia and treat the patient. So whenever you find microangiopathic hemolytic anemia as a complication for systemic sclerosis, please do look for the blood pressure, which is usually more than 170 by 90. And then there is AKI, which is following. And then there is angiopathy that is going on. There is hemolytic anemia that is going on. So in the peripheral smear, you will find cystocytes. Very important. Next, we talk about the Complications of systemic sclerosis related to the heart. Patient complaining of sharp pain not related to the inspiration or expiration. We don't understand what it is. But when you think of telangiectasia, when you see sclerodactyly, when you see digital ulcers, calcinosis cutis, you will understand that this patient has got pericarditis. Pericarditis is an inflammatory pain which is not related to inspiration or expiration. Whenever the patient has got a pleuritic pain on inspiration, it is pulmonary embolism until otherwise proved. If the patient has got pain on both inspiration and expiration, it is pleuritic pain that is called pleurisy. In systemic sclerosis, the complication of a question framed by the examiner will be this way. A middle-aged gentleman with history of difficulty swallowing, knee pain, presenting with fatigue, weakness, and shortness of breath. He has a rub on auscultation unrelated to the change in the diagnosis breathing pattern. That is pericarditis because with each and every heartbeat, there will be a sharp friction rub that we can hear on auscultation. I'm not worried about myocardial fibrosis, but I'm worried about pericardial effusion. Remember, and large pericardial effusion requires paracentesis or pericardiocentesis. That is what you need. You need to remember. Next, we will talk about scleroderma renal crisis. Very common question you will find in the examination that is framed by the examiner, which mentions that this patient has got hypertension, or this patient is presenting with visual blurring, or the patient presents with the blindness. Can everyone mute their mic, please? Thanks. Patient presents with confusion, patient presents with blindness in one eye, or patient presents with sudden onset of blindness. On full blood count evaluation, patient was found to be thrombocytopenic, but patient has got hypertension, patient has got signs of systemic sclerosis. And now this patient presents with acute anemia, saying that the hemoglobin is decreased. There is increased LDH, there is decreased haptoglobin. That points towards the diagnosis of microangiopathic hemolytic anemia. Not only you'll have to think of microangiopathic hemolytic anemia, but whenever there is increased blood pressure and renal failure, you'll have to think of scleroderma renal crisis. What do you have to do whenever you find renal crisis? You'll have to first treat hypertension. When you first treat hypertension, the drug of choice for scleroderma renal crisis is captopril. Remember, for ACE inhibitors, elevated serum creatinine level is not a contraindication because there can be elevated serum creatinine as well. But the most important problem is we'll have to make sure that the patient is not dying. With more hypertension, with more renal decreased perfusion, there is more thrombocytopenia, there is more of microangiopathy going on. We'll have to control this hypertensive emergency that can treat encephalopathy in this patient. So please do select captopril or a short-acting ACE inhibitors is what you'll have to find out. When we talk about the types of systemic sclerosis, it is the limited systemic sclerosis and diffuse systemic sclerosis. Whenever I say limited sclerosis, it is the crest syndrome that happens to be appearing in limited cutaneous syndrome. Remember, there is prominent Raynaud's phenomenon whenever there is limited cutaneous sclerosis. So in the question, you will find that the vascular manifestations will be prominent in limited cutaneous sclerosis along with crest syndrome. That is, whenever I say vascular manifestations, it is the Raynaud's phenomenon, it is the telangiectasia that you'll need to see, and it is the pulmonary arterial hypertension that